Okay, thank you, Tom. Good afternoon, everyone. So today I'll talk about IgG glycome as biomarker and effector of CVD risk. So when we talk about cardiovascular diseases, then we are talking about a group of disorders of the heart and blood vessels, and they are still #1 killer worldwide. But fortunately, situation is it's changing because now, as you can see, that in high income countries, there is actually decrease of deaths related to cardiovascular diseases compared to low income countries. So why is that? Because we learned that there are some risk factors which can be modified, and we that integrated in some our preventive measures, and thus we consequently reduce number of deaths related to cardiovascular diseases. But to reduce number further, we have to identify other novel risk factors, and since here we are talking about glycans, it's obvious our question, are the glycans actually the next biomarker or risk factor for cardiovascular diseases, and are they modifiable? So we know already that numerous cardiovascular diseases are associated with changes in protein and glycosylation, and you can see that at molecular and cellular level. For example, in different arrhythmias, you expect that there are going to be changes in cellulation because it is charged sugar, and of course that it can impact mobility of charged ions. Also in some cardiac hypertrophy and heart failure, you have some tissue rearrangements, and you expect also there are going to be changes in some structural proteins and also in receptors. But when you have some more complex diseases such as with complex pathology, such as atherosclerosis, then you see a wide range of changes in glycosylation, ranging from changes in endothelial cells to changes in lipoproteins and also in immunoglobulin G. We talked yesterday and today a lot about structure of IgG, so and its function and its effector function. So I'll skip this part, and just to remind you about importance of each individual monosaccharide which is attached to IgG glycans and its function. So absence of actual presence of cellulation and core fructose, it is associated with lowering affinity for different Fc gamma receptors. What Gesture also yesterday said that with galactose, the story is not so simple. Most changes which we see in IgG glycome related to different diseases are actually related to lower cellulation and galactosylation, and also other monosaccharides are changed in different diseases, and cardiovascular diseases are not different when we look at that, and as I will show you later. Also, we know that genes that regulate IgG glycosylation are implicated in multiple diseases and conditions, and you can see here that some of them are risk factors or are associated with development of cardiovascular diseases, such as total cholesterol, HDL, or LDL level. So First, I'll start with association of IgG glycome with risk factors, and hypertension is probably the best known risk factor for development of cardiovascular diseases. And we show in different cohorts that there is increase of agalactosylated and acylated structures from the state of pre-hypertension to hypertension. Pre-hypertension is state when you have high blood pressure, quite high, but not high enough that it can be classified as hypertension. But IgG glycome is already changed in that state. Of course, unsurprisingly, that parallel with increase with those agalactosylated and acylated structure, you have also decrease of structures which are having two galactoses. Also, we show that N-glycosylation of immunoglobulin G correlates with incident hypertension, and you can see here glycans which are related to incident hypertension and all hazard ratios related to them. Here again, you can see that those structures without galactose and sialic acids and with bisecting are related to incident hypertension, while those sialylated and galactosylated structures are negatively associated with incident hypertension. We show that in two cohorts in Twins UK, that's Tim Spector's cohort from King's College, and also on Croatian cohort of 10,001 Dalmatians. Which obvious question which is arising from that is, are those changes somehow related to development of hypertension? We for sure don't know answer for that, but there are some data which indicates that could be effector function of IgG in development of hypertension. One of these is that Fc gamma receptor 2b somehow stabilize angiotensin receptor on smooth muscle cells. And what is also known that people with hypertension also have higher levels of immunoglobulin IgG in their circulation. And you also probably know that angiotensin is one of the main targets of many antihypertensive drugs. What we also know that affinity of those glycans which I mentioned earlier, which are agalactosylated, acylated, have higher affinity for that Fc gamma receptor 2b compared to those which were constantly negatively associated with two sialic acids. Is it possible to modify then that risk factor? For now, we don't know for humans, but at least in mice, supplementation with N-acetyl-D-manazamine or MANAC helps. MANAC is a direct precursor of sialic acids, and when mice were put on high-fat diets, as we also do, we get increase in body weight, and parallel with that, there is increase in blood pressure. But when their diet is supplemented with MANAC, there was also increase in their body weight, but there wasn't increase in blood pressure. Also, IgG became more sialylated compared to those IgGs which are coming from mice from just high-fat diet. Besides hypertension, IgG glycosylation also changes in dyslipidemia. So dyslipidemia is a condition when you have disbalance of different lipids, lipoproteins, and triglycerides. And you can see here that again, those structures without galactose are positively associated with dyslipidemia, while those structures with 2 galactoses and 1 sialic acid, that structure GP18, how we call it, is negatively associated with dyslipidemia. We also show that N-glycosylation of immunoglobulin G strongly correlates with 10 years atherosclerotic disease risk score. So that risk score is calculated from known risk factors and predicts development of atherosclerotic diseases. And you can, first we did study in Twins UK, and you can see that those agalactosylated acylated structure with bisecting were positively associated with that risk score, while those structure with 2 galactoses, 1 sialic acid, which we already mentioned before, which was associated with dyslipidemia, what is expected. Because dyslipidemia is one of the factors included in calculation of that atherosclerotic disease risk score, and this what we call GP9 structure, which is structure which carries 1 galactose on 3 arm. After we obtained those results, we replicated that in orchids, and those glycans were replicated. Also, those glycans, similar as you saw in hypertension, there was, so we developed based on that glycan risk score, and as glycan risk score was increasing, also was increasing that atherosclerotic risk score. Also, there was association between presence of carotid femoral plaque. Why is that important? Because those are markers of asymptomatic coronary artery disease, and those associations with glycans remain significant even after we corrected for all known risk factor. Here again, you can see that this structure, which was related with dyslipidemia, was lower with people having carotid or femoral plaque, and also was negatively associated with a concentration of very low density lipoprotein. So after that, we did IgG glycome association with incident cardiovascular events, and we did this first in EPIC postdam cohort, and we did sex stratified analysis because it is known that cardiovascular diseases, men and women, behave differently. You can see that in men, DCL-related and degalactosylated structure was constantly negatively correlated with cardiovascular events, compared, and that was significant. Even we corrected, as you can see here, almost everything we could think of that can have impact on those cardiovascular events, while in women the only structure which was significant was that GP9 structure, which is having that galactose on its 3 arm, and it was also remained significant even correction now all known factors. Recently, we replicated this in another 2 cohorts. Those cohorts are Jupiter and TNT. So Jupiter is cohort where are patients receiving statin therapy for primary prevention for cardiovascular events, while TNT is for secondary prevention. And glycans which are associated with primary and secondary cardiovascular events are those positively associated with cardiovascular events are those without galactose and sialic acids, while those galactose-related were negatively associated. You can see here that GP9 structure was negatively associated, but only for primary prevention of cardiovascular events. This is interesting when we also look at plasma glycome, and so the only significant glycan in women in all plasma glycome was actually a structure that we call GP9, which is coming from IgG, while in men situation was much more complicated. When you know all this, it is not surprising that actually IgG glycosylation is altered in coronary artery disease, which is actually a direct consequence of atherosclerotic changes. And here we can see that in women there was, so this is done in Capire cohort, where patients were recruited who had all the same risk factors, but some of them developed coronary artery disease and some of them didn't. And you can see that in those who developed in women, there was higher presence of CL-related, agalactose-related structures, while was lower presence of CL-related ones. The second disease, which can have different pathology than coronary artery disease, but mostly atherosclerotic changes are actually the main cause of it. Also, there was increase of those agalactose-related, ACL-related structures and decrease of CL-related ones. Also, here we see that in patients who developed heart failure, it was lower abundance of oligomannose ones. The next cardiovascular disease have different pathology, and this is atrial fibrillation. And here you cannot see those changes which I'm already mentioned. It contrary has the opposite. The effect of changes in the opposite direction compared to atherosclerotic ones. So you can see that GP9 structures, which was constantly being protective in atherosclerotic cardiovascular diseases, here is actually increased in patients who developed atrial fibrillation, while also there is increase in CL-related and glycans. But also when we calculated CHA2DS2-VASc score, so CHA2DS2-VASc score is a score which predicts stroke. And it's similar to 10 years atherosclerotic disease risk score, because it's also based on known risk factor for stroke. And you can see that because, as I showed you earlier, that glycome is changed in many of those risk factors. So you can see that in that score that is decrease of those galactose-related and CL-related structures, while there is increase of agalactose-related ones. When we are talking, so since we in glycan switch we are talking about rheumatoid arthritis, it is known that there is higher prevalence of cardiovascular diseases in patients with autoimmune diseases, and mostly if you look at it, we mostly correct when we look for cardiovascular disease, we actually correct data for autoimmune diseases. Now it would be interesting to see actually are there any specific patterns of glycosylation which can distinguish people with autoimmune diseases which are going to develop cardiovascular ones. What we know already that changes in IgG and glycosylation in rheumatoid arthritis, they are happening at least 10 years before the patients develop symptoms and are diagnosed with rheumatoid arthritis. And those structures are those which we already saw that are related to development of atherosclerotic cardiovascular diseases. So also it is a plan, as you saw that mentioned GP9 structure quite often during this presentation to do a huge meta-analysis and see if GP9 is a predictor of cardiovascular health. We already have at least 9 cohorts which are PIs who agreed to include in this study. And I welcome all of you who have information about disease from deaths from cardiovascular diseases in your cohorts, and also measured glycemic data to join us in this study. So at the end, I would just like to thank you all people in Genus to making those results I presented, and thank you all for your attention.
Are there questions? So let me kick off. I think I'm very convinced by the association studies, but you also said something about that the IgG glycan is binding to FcR2b. So that is a more causal.
Yeah, because when you look from clinical side, you know that when some biomarker is increasing as the disease is progressing, usually it means that actually it has some effector function. And I believe IgG Glycome has it, but in this study they didn't look at role of IgG Glycome on development of hypertension, but it's for surely it's worth testing.
Like the morning showed with glycan H as a biomarker, if you use, let's say, IgG glycan as a biomarker, is it reversible over time? So if I go jogging and eat 800 calories and things like that, is it going then down or?
I don't know. As a colleague Nina presented, it depends. It has different effect on different persons. So there's no, except for calorie restriction.
This is all. Hi. Thanks for the interesting presentation with these diverse signatures for the different types of CVD. So for the GP9 in women, which associates with this atherosclerotic risk, could we measure this also at the glycopeptide level, or is the 6-arm signal completely blurred, the 3-arm signal? Have you looked into this?
We haven't looked at, but probably is blurred. Yeah, because you cannot.
It's an assumption, but have you tested this? So
No, we haven't tested.
We have data in some cohorts sometimes.
We did look in some cohorts, in the subset cohorts from Karolinska, and then they do see effect also in G1.
Okay.
G1 is monocalculated, measured by mass spec. So
But you cannot distinguish 3 from 6 out.
Of course,
yeah, but even when you add them, you still have some signal.
Yeah. So if you do a proxy and you sum your 3-arm and 6-arm signal, because you could do that as a simulation, you know?
Yeah, but
you can then still get the associations.
yeah, but I know from multiple sclerosis, you have the opposite effect. So 3-arm is decreasing and 6-arm is increasing. So if you are
So the best now. So in general, do you have the association still if you sum?
I don't know.
Could you test it?
Yeah, we could test it. Yeah, we have it.
It gets to it.
just a short comment. One of the general problems we have is that a lot of our clinical collaborators do not share the individual level data. So So we don't get, for example, in most of our cohorts, we do not know who had a higher blood or not. So they do the analysis. And then we have to tell them specifically what to do.
Yeah.
And each additional analysis we add, it's kind of increasing the multiple corrections. So we try to go for a limited number. In theory, yes, we could do it, but we didn't do it because we tried to play by the book. So we don't do everything and then just select for the publication.
Yeah, it's horrible that doctors sometimes don't share things, which are all kind of legal things. So to play by the book is also, yeah, I guess, usable.
Okay, I get it. No, it's a very nice talk. So, cause of consequence. So I think your tendencies that you see, there are clear correlations with the alkylated form and the severity of the disease or chance of getting it. But do you think it's a functional cause, or is it a sort of a side effect of ongoing inflammation?
Yeah, I think it has causal effect. So because we didn't see that in, we know for that study in mice. So they got inflamed because of they developing obesity, and obesity is actually inflammation state. So you would expect then that they would anyway develop hypertension, but they didn't after that sialic acids added back to IgG glycome.
It's very interesting, and there's lots of questions that maybe we would go for a coffee. So it's my pleasure now to invite Rudy and give the hand.